Hello, my name is Carolyn Rowland. I am a maternal child health public health nurse at the Detroit Department of Health and Wellness Promotion. This is the City of Detroit's health department here in Detroit, Michigan. And today I'm pleased to be able to talk with you about pre- and interconception care, its importance in combating our persistent problems of maternal and infant mortality, and the critical role that primary care providers play in assuring patients of childbearing age receive recommended care. At the end of this presentation, participants should be able to define preconception care, identify the risks that are amenable to intervention, identify risk screening tools, describe ways that preconception care can help reduce both maternal and infant mortality and morbidity. The CDC Select Panel defined preconception care as a set of interventions intended to identify and modify risks to women's health or pregnancy, focusing on factors that must be acted on prior to or very early in pregnancy to be maximally effective. For today, the term preconception care will be used to describe both preconception care, care that is provided prior to a first pregnancy, as well as interconception care, care that is provided between pregnancies. Providing care before and between conceptions to optimize pregnancy outcomes is not a new concept. A 1985 Institute of Medicine report on preventing low birth weight discussed the importance of minimizing risk before pregnancy. The 1990s March of Dimes education curriculum, Babies and You, was designed to educate the larger community on the importance of risk reduction prior to conception, as well as planning for pregnancy. And a 1992 Port report on prenatal care described the preconception visit as the single most important prenatal visit. Preconception care is more than traditional family planning, but it's also less than comprehensive primary care. The attention to identification and reduction of reproductive health risks is what makes it unique. However, preconception care really has to be fully integrated into primary care if we're going to achieve a significant reduction in adverse pregnancy outcomes. The renewed interest in this area of prevention is driven by the increase in preterm births, a lack of progress in reducing maternal and infant mortality rates, persistent racial and ethnic disparities, and the fact that few patients of childbearing age actually receive recommended preconception services. As illustrated in the graph, the rate of preterm births, that is births at less than 37 completed weeks of gestation, has gone in the wrong direction. There was an increase of 36% between the 1980s and the 2000s, reaching a high of 12.8% of all U.S. births in 2006. Although the preliminary rate for 2010 was 11.9, which continues a very gradual downward trend, our percentage of preterm birth still exceeds the rates that we're seeing in the 1980s and the 1990s. We actually lead the world in the percent of preterm births at this point. High preterm birth rates contribute to rising healthcare costs. According to a 2006 Institute of Medicine report, preterm births cost the United States more than $26 billion annually. On average, a preterm birth costs $75,000, about 7 times the $11,000 cost of a normal full-term birth. Preterm birth also exacts a tremendous human cost. It is the leading cause of neonatal death and a major contributor to infant morbidity. Approximately 25% of the smallest preterm infants, those weighing less than 2 pounds at birth, as illustrated by the preterm baby there on the left have developed serious long-lasting disabilities. So that's a quarter of all of these infants. But it's estimated that up to 50% or half of these very small babies end up with mild learning disabilities and behavioral problems. Cerebral palsy, visual impairments, and hearing deficits are common among preterm births. Even babies born just a few weeks early have higher rates of hospitalization, illness, and death than full-term infants. The mortality rate for infants born between 34 and 36 weeks gestation is 3 times that of infants born at term. There are also significant racial disparities in preterm birth rates. The rate of early preterm births for African American women is 2 to 3 times that for white women. Infant mortality is a key indicator of the health and well-being of populations, communities, and nations. The U.S. infant mortality rate is higher than that of many other industrialized nations. We ranked 30th in international standings in infant mortality in 2005, and our ranking has been dropping for almost 40 years. In the 1960s, we ranked 12th. Now we're down to 30th. Infant mortality, as similar to preterm birth, is costly in terms of human potential and dollars. Caring for high-risk pregnancies and sick babies costs the U.S. tremendous amounts of resources each year. In addition to the immediate costs, there are long-term costs for health care, family services, and special education. As you know, mortality rates are the tip of the iceberg, revealing only a small portion of the disease and disability affecting our youngest citizens. As you can see on the graph here, U.S. infant mortality rate is not really increasing, but the rates have been stagnant since the early 2000s, ranging from 6.68 to 6.85 infant deaths per 1,000 live births. Preliminary national data for 2008 and 2009 show an overall downward trend, but racial disparities in infant mortality rates persist. Again, as you can see, African American babies, represented by the light blue bars, continue to die at 2 to 3 times the rate of white babies. Native American babies die at 1.5 times the rate of white babies. Maternal mortality is another key MCH indicator, and although these rates fluctuate year to year, there's been no sustained improvement in 2 decades. The 2006 maternal mortality rate was 13.3 deaths per 100,000 live births. That compared to a rate of 7.9 in 1989. The increase in the rate has been attributed largely to reporting changes. The introduction of the ICD-10 codes in 1999 and the addition of a separate pregnancy status question on the U.S. Standard Certificate of Death in 2002. Thus, these higher rates are a result of improved identification of maternal deaths rather than an absolute increase in the number of deaths. But again, as you can see, there are large and persistent racial disparities. The red bars are the U.S. rates, the light blue bars are the rates for white mothers, and the dark blue bars are the rates for African American mothers. In 2006, African American mothers in the United States died at a rate of 32.7 per 100,000 live births. That's more than 3 times the rate of white mothers, who died at a rate of 9.5 per 100,000 live births. This disparity is one of the most pronounced in maternal child health, and again, as you can see, it's not decreased in over 30 years. So where have we been? There has been a great deal of effort invested in reducing both infant and maternal mortality over the past 4 decades. We've yet to achieve the Healthy People goals for a variety of key maternal child health measures, but the efforts have made a difference. Care of preterm and sick newborns has been revolutionized. The discovery of surfactant, as well as the development of NICUs, specialized equipment, and technologies that allow intrauterine intervention, have resulted in a marked reduction in infant mortalities between the 1970s and the 1990s. Efforts have been made to enhance the quality of prenatal care and to increase access via expansion of Medicaid eligibility. Outreach and support programs such as Healthy Start were implemented to address infant mortality at the community level. More women are getting early prenatal care. The percent of women entering care in the first trimester increased from 76% in 1980 to 83% in 2001. Furthermore, the percent of women receiving late or no care declined almost 50%. It was 6% in 1990 and fell to 3.7% in 2001. Increased expertise in maternal fetal medicine, including the Maternal Fetal Medicine Units Network of the National Institute of Child Health and Human Development, has enhanced care for mothers and infants by identifying new therapies, evaluating technologies, and helping to abolish practices that were not useful. But in spite of past progress, the paradigm on which much of our efforts were based, that of healthy mothers equals healthy babies, has not been effective in addressing the persistent problems. Access to prenatal care is necessary, but it's too little and it's too late. Improved neonatal intensive care has resulted in reduced mortality rates, but has not led to comparable reductions in morbidity. In 2005, the CDC led a call for a paradigm shift in thinking about the problems of infant mortality and morbidity. Work on the life course theory, social determinants of health, and racial disparities has reaffirmed the need to move the focus upstream. It's long past time to stop pulling babies out of the water and start working to assure women are healthy long before they're ready for motherhood. Preconception care builds on this new paradigm. Healthy women equal healthy mothers equal healthy babies. Primary care providers are critical in making this paradigm shift a reality. They see patients when they're not pregnant, perhaps not even thinking about parenthood, but when problems can be most effectively addressed. They have the opportunity to impact life before it ever begins, to assist patients in creating a safe, healthy environment that facilitates the complex and wondrous process of human reproduction. This chart further illustrates the importance of moving our efforts upstream. Congenital malformations, the dark blue triangle there, are the leading cause of infant mortality and morbidity in the United States. They accounted for 20% of infant deaths in 2007. Malformations arrive during organogenesis, which occurs during the first 12 to 13 weeks of gestation. Although the cause of many birth defects is unknown, increased risk is associated with inadequate nutrition, obesity, poorly controlled diabetes, alcohol use, smoking, exposure to teratogens, and extremes of reproductive age. Prematurity and low birth weight, the second leading cause of mortality and morbidity, accounted for 17% of the infant deaths. That's that magenta triangle. Although there's no single etiology for preterm birth or low birth weight, women who smoke, are underweight or overweight, have active infections, have chronic health problems such as diabetes and hypertension, experience high levels of stress, and are subjected to domestic violence are at greatly increased risk for these adverse outcomes. Many risk factors are amenable to intervention, but women require care, information, and support before conception if the interventions are to be maximally effective. Every healthcare encounter with men and women of childbearing age should include basic preconception counseling. And for women, we're generally talking women between 14 and 45 years of age. This is important because approximately half of the pregnancies in the United States are unplanned. They're not necessarily unwanted or unwelcome, just not planned. And in these instances, couples may not even be aware of the need to reduce or avoid risks. Furthermore, when pregnancies are planned, they're rarely planned with healthcare providers. It's estimated that only 1 out of 6 primary care providers, and that includes obstetricians and gynecologists, offer preconception care to their patients. Thus, we miss many opportunities to educate patients about medical and genetic risks, as well as common teratogens such as alcohol. Finally, most women don't begin prenatal care until the end of the first trimester or the beginning of the second trimester. At this point, organogenesis is complete, and the opportunity to minimize the risks for congenital malformations is past. Underserved communities, poor communities, and communities of color bear a disproportionate burden of reproductive health risk. But patients do listen and respond to their primary providers. Targeted health education messages and interventions have been shown to be effective in changing behaviors that pose serious reproductive health risks, such as substance abuse. Primary providers serving these communities have a real opportunity to address the disparities in maternal child health by integrating preconception care into their daily practice. The key components of preconception care are risk assessment, health promotion, and interventions to reduce identified risks. Reproductive risk assessment covers many sensitive topics. Normalizing the assessment and careful phrasing of questions facilitate the process. The presence of written materials such as posters and brochures about issues like domestic violence can help reassure patients that discussion of these topics is a routine part of care. An overall assessment of each patient's physical and mental health status provides the basis for testing, referral, counseling, and treatment. A standard history and physical usually provides enough information to begin preconception counseling. One resource, Every Woman Southeast, houses webinars on risk assessment, patient education materials, and publications. Identification of chronic health conditions is a critical component of risk assessment, since the health of women with chronic conditions can be negatively affected by pregnancy. In turn, fetal health may be compromised by the presence of a chronic illness. Women over 35 and women of color are disproportionately affected by conditions such as diabetes and hypertension. Pregnancies in women with type 1 diabetes are at increased risk for congenital malformations and stillbirth. It's estimated that as many as 25% of pregnant women with chronic hypertension will develop preeclampsia, and that's compared to 6 to 8% of the general prenatal population. Preeclampsia increases the risk for preterm delivery and other complications such as placental abruption. A report from the National High Blood Pressure Education Program at the National Institutes of Health noted that hypertensive disorders accounted for 15% of maternal deaths in the U.S. Risks to both mother and baby can be decreased when chronic conditions are well controlled. A range of genetic conditions can affect reproductive outcomes. A comprehensive history is necessary to determine if additional counseling or referrals are needed. All patients with known heritable conditions such as sickle cell anemia, cystic fibrosis, and G6PD should be offered genetic counseling services prior to conception. Specific questionnaires can facilitate screening for genetic risks. The Preconception Prenatal Family Health History Questionnaire can be obtained from the March of Dimes. The prenatal screening questionnaire comes from the American Medical Association. Both of those tools can be downloaded for use. Assessment of lifestyle factors that influence pregnancy outcomes is part of preconception care. Either extreme of the weight continuum, overweight or underweight, is associated with an increased risk of adverse outcomes. But there is an increasing burden of overweight and obesity due to the high prevalence of these conditions. Approximately 1/3 of all women in the U.S. are currently obese. Inadequate nutrient intake increases the risk for congenital malformations, as exemplified by the established relationship between folic acid levels and neural tube defects. Nutrient intake can be compromised by food choices and food availability. Access to healthy, nutritious foods can be compromised by limited economic resources. Nutrient intake can also be compromised by disordered eating patterns. ACOG estimates that 7 million girls and women in the U.S. have eating disorders. Substance use is common among women of childbearing age. A 2007 analysis of PRAMS data from 26 reporting areas across the U.S. revealed that of the women who had recently given birth, 23% used tobacco and 50% used alcohol in the preconception period. Chronic stress is also associated with adverse pregnancy outcomes. Again, according to the PRAMS survey, almost 1/5 of the women responding experienced at least 4 major stressors prior to becoming pregnant. Intimate partner violence is another risk factor for adverse pregnancy outcomes, as well as contributing to maternal morbidity and mortality. Reports on the prevalence of violence vary widely. Only 3.6% of the women in the 2007 PRAMS survey reported being physically abused. But a 1999 Commonwealth study found that 31% of all women reported abuse at some point in their lifetime. Finally, exposure to chemicals and toxins pose a risk to fetal development. Women working in industries such as agriculture, manufacturing, dry cleaning, printing, pharmaceutical manufacturing, and healthcare are often exposed to harmful chemicals, including heavy metals and solvents. There are a variety of tools available to facilitate risk assessment for lifestyle factors. BMI, of course, is the recommended measure for weight. CDC has a range of online calculators that patients can be encouraged to use to find and track their own BMIs. 2 short alcohol-specific screening tools, the TACE and the TWIG, have been validated for use with women of childbearing age. There are a variety of tools also available to screen for stress, but many of them are lengthy and relatively complicated. Adding 1 or 2 validated questions to a history should be sufficient to determine if further assessment is needed. One validated question: in the last month, how often have you felt difficulties were piling up so high you could not overcome them? With an answer scale of never, almost never, sometimes, fairly often, and very often can be used. Responses of fairly or very often indicate a need for additional assessment. Specific screening tools are available for violence. The 2 listed, the HITS and the PVS, have been validated for use with both men and women. If the use of a specific screening tool is not feasible, key questions can be added to existing protocols or forms. A single screening question, "Do you feel safe at home?" had been recommended, but there's now conflicting evidence about its validity. The 3 STAT questions seen on the slide here, when used together, have been shown to effectively identify abuse in women. As with domestic violence, Questions about substance use can be added to existing protocols. Screening questions, guidance for introducing the subject to patient, and scoring instructions are included in the resource guide, Screening for Drug Use in General Medical Settings, available from the National Institute on Drug Abuse from the NIH, and the website is listed there. That's a very comprehensive tool that you can use to guide a great deal of assessment. Finally, a thorough reproductive history is a critical component of the risk assessment. Standard history and physical content on reproductive history and contraceptive use may not be sufficient for preconception risk screening. Direct questions about pregnancy intention and contraception are necessary to guide care. The fetal infant mortality reviews that we've conducted here in Detroit suggest that women in their late 30s and early 40s are not consistently asked about pregnancy intention or contraception. In reviews of deaths of infants born late preterm, most of the mothers had multiple risk factors. Many were over 35, had at least one chronic illness, prior history of reproductive loss, and yet there was little evidence that they were ever counseled on the risk of pregnancy to themselves or to a developing baby. Given that most of the women had young children, it would seem reasonable to assume that they were indeed sexually active. And again, I don't know if assumptions creep in here, if women are of a certain age, perhaps chronic illness, perhaps obese, that perhaps marital status is single, that we just assume they're not sexually active is not valid. So a more detailed sexual history is really often necessary to adequately assess the risks. But this is an area where patients and providers may have difficulty communicating. One helpful tool to facilitate communication around sexuality is the CDC publication, A Guide to Taking a Sexual History. Again, this includes suggestions for introducing the discussion, conducting the assessment, and for counseling. The 5 P's, partners, practices, protection from STD, past history of STD, and prevention of pregnancy are all addressed in the publication. And again, this is available from the CDC website seen here on the slide. Health promotion and education are provided to all patients to make sure they have the information needed to promote and protect their health. For some patients, health education may be the only intervention that's needed. The importance of positive health habits has to be reinforced regularly. Educating patients that behaviors within their control, healthy eating, rest, exercise, maintaining positive relationships, and avoiding substances can significantly contribute to their overall health and well-being, and that can be very empowering to patients. Adequate nutrition is vital for health, but it's especially critical before and during pregnancy. Women should be advised to take multivitamins with 400 micrograms of folic acid per day. Adequate folic acid intake has been shown to decrease the occurrence of neural tube defects by 50%. Guidance on healthy eating and physical exercise can help women reach and maintain a healthy weight. The recently released Dietary Guidelines for Americans 2010 is a comprehensive resource for providers and families that's available online. Patients should be educated about the negative effects of substance use on their health and on the health of a developing fetus. Tobacco use is the leading cause of preventable death and disability among women. There are multiple adverse effects on the fetus if women smoke during pregnancy. Tobacco use also affects those individuals who live around a smoker. Women who live with individuals who smoke should be advised about the negative effects of secondhand smoke, especially during pregnancy or if they have small children. Clear, consistent advice that there is no safe level of alcohol consumption during pregnancy has to be provided regularly. Women should be informed that prenatal alcohol use is a leading cause of preventable birth defects and developmental disabilities. Those planning to become pregnant or those not using an effective method of birth control should be advised not to drink at all. Women who wish to drink need to be counseled on the use of an effective method of birth control. When educating patients about the effects of drugs on pregnancy, over-the-counter and prescription drugs have to be included in the discussion. Illegal drugs are not the only drugs that cause problems. A number of over-the-counter drugs and prescription drugs are known teratogens. If illegal drugs are used during pregnancy, families should be advised not only about the physical risks to mother and baby, but about the legal ramifications, including the involvement of Child Protective Services. Patients should be educated on the recommended spacing between pregnancies, 18 months from the end of one pregnancy to the beginning of the next. This allows sufficient time for the mother's body to recuperate and for the family to fully integrate one baby before another is added. To help prevent unintended pregnancies, patients should be educated about all available birth control methods, including the benefits and risks of each method. A variety of resources are available to help determine the best method for each patient. Fact sheets available from Health and Human Services include a series of questions that are very helpful for individuals when they're trying to decide on a birth control method that best suits their specific needs. Health promotion should also address the psychosocial aspects of pregnancy and parenting. Patients planning a pregnancy should be counseled about preparation for parenthood. Children are a blessing, but they're also a profound responsibility. Parenting is a full-time job that requires time, energy, resources, and patience. An inventory of stressors and supports can help families identify what resources may be available to help them meet the many challenges of raising children. Lastly, patients can be assisted to develop a reproductive life plan. This can facilitate active preparation for parenthood by helping patients to think about the number of children that they want. When they want those children, in their 20s, in their 30s, after college, before grad school, how far apart do they plan to have their children? Every 2 years, every 5 years? And then how do children fit into their other life goals? Work, travel, education. Also to assure that partners are actually in agreement about the number and spacing of their children. It is sometimes amazing the lack of communication about this very important aspect of relationships. And then also, are partners in agreement about family planning methods? Many methods actually require the cooperation of partners, so they need to be on the same page for that. When risks are identified, they must be addressed before conception to minimize damage to a developing fetus. In some instances, conception should in fact be delayed until a risk has been eliminated or modified to the fullest extent possible. Given the many screening, diagnostic, and treatment tools available, our goal should be to eliminate fetal exposure to unnecessary risk, things such as alcohol, tobacco, sexually transmitted infection, and vaccine-preventable illnesses. preconception care really is primary prevention at its best. For women with a chronic disease, the goal is the best control possible. A thorough assessment and review of the treatment regimen is indicated. If a condition is poorly controlled, the reason needs to be identified. Perhaps the regimen is too complicated or not comprehensive enough. And once identified, a plan to correct the problem can be developed. A decision about the management of chronic conditions during pregnancy should be made before conception. Will the primary care provider continue to manage the condition, or will the OB provider assume temporary management? Finally, all medications should be reviewed. Those that are known or suspected teratogen should be changed. Sexually transmitted infections can have a profound effect on a developing fetus, but most are actually easily detectable and many are curable. It's estimated that 33,000 people in the United States contract a sexually transmitted infection each day. Thus, all sexually active patients need to be counseled on safe sex practices. Testing and treatment for STIs and HIV is conducted as needed based on your screening and risk factors. If acquired during pregnancy, several vaccine-preventable illnesses can result in miscarriage, stillbirth, and birth defects. Based on history and titers, women who are not immune to measles, mumps, rubella, or varicella should be vaccinated. They should be counseled on the importance of using an effective method of contraception for 30 days post-vaccination. Oral infections such as gingivitis are very common among low-income populations and are associated with an increased risk for preterm birth. Therefore, women really do need to be referred for dental care when it is needed. The 5 A's are a really useful framework for initial intervention with patients who use tobacco, alcohol, and other drugs. Ask direct, open-ended questions about substance abuse. How many? How much? Rather than closed questions such as do you. Give strong, direct, personal advice about the consequence of the substance use and encourage the patient to make a change. The risk to the developing fetus and the ability of the patient to eliminate the risk need to be emphasized. And again, the advice has to be personal for that patient and coming from you, the provider. Assess the patient's readiness to change behavior. Assist the patient to make a change. Develop a change plan together. Prescribe medications. If the patient is not receptive to change, the assistant should focus on pregnancy prevention. Arrange for further assessment and treatment for all high-risk patients. Patients at moderate risk may very well be managed by a primary provider or referred if needed. And then arrange for follow-up. Follow-up is very important. The goal for patients using tobacco, alcohol, or drugs who are likely to become pregnant should be complete cessation. Strong, clear messages that all substances can increase the risk for adverse pregnancy outcomes, including mortality and morbidity, should be reinforced. Treatment resources, including detoxification, inpatient, and outpatient facilities, can be found at SAMHSA's online treatment locator. State substance abuse agencies and other useful resources are also available at this site. While managing weight problems is challenging to say the least, it is a critical component of preconception care, as both underweight and overweight increases the risk for adverse reproductive outcomes. Overweight also influences the effectiveness of hormonal contraceptives, which can compromise pregnancy prevention goals. Following assessment to rule out underlying disease, the first step is to jointly establish goals for an appropriate weight. To minimize risks to the woman and to future pregnancies, the desired weight should be achieved prior to conception. For women who are underweight, treatment should include education, a dietary prescription, and regular monitoring. For women who are overweight or obese, education, a dietary prescription, recommendations for physical activity, and behavioral therapy if indicated, along with regular monitoring are indicated. Weight maintenance is a really critical component of treatment once the desired weight has been achieved. Weight loss surgery might be considered for women who are morbidly obese. Addressing psychosocial risks can also be challenging. Interventions may be compromised by a patient's inability to follow a risk reduction regimen or to properly use contraception. However, these same issues can compromise the patient's ability to effectively parent. Thus, psychosocial risks are much more effectively managed before pregnancy rather than after. Depression is common in adults of childbearing age. Patients with mental health issues such as mild depression and stress can be treated by primary care providers. Those with significant mental illness do require referral to a mental health specialist. A lethality risk for violent relationships should be conducted to guide intervention. If there's imminent danger, assist the patient to leave the situation and get to a place of safety. If the danger is not imminent and the patient is not prepared to leave, you need to make sure that she has a safety plan. Preconception care is for men too. Their general health influences the health of their partners and their children. Men can improve their reproductive health in much the same way as women, reducing stress, eating right, avoiding substances, talking to their providers about their medications. Understanding the genetic risks from both the mother and the father enables providers to give more accurate advice. Men should also be assessed for immunity to vaccine-preventable illnesses. Screening and treatment for STIs minimize the risks of their infecting their partners. Men should be screened for substance use, treated and referred just as women are. Those who smoke should be educated on methods to minimize exposing their partners and families to secondhand smoke while they work through cessation. Men who work with chemicals or other toxins need to take precautions to avoid exposing women to them. Fathers also play a critical role in the development and well-being of children. They should be educated on the responsibilities of parenthood just as women are. In fact, couples should ideally be educated together. Protecting the health and well-being of our children is in everyone's best interest. Combating infant death and disability uses tremendous amount of resources, money, equipment, skills, time, and provider resources. A 2006 report from the CDC stated that the direct and indirect societal cost for each child born with an intellectual disability or comparable condition was in excess of $1 million over their lifetime. Just think how many kids we could send to college with that kind of money. Primary care providers have the unique opportunity to minimize the risk of adverse outcomes, reduce cost, and improve the quality of life for women, children, and their families through the routine implementation of preconception care, protecting the health of the next generation by promoting and protecting the health of their parents. Primary prevention at its very best. There are many resources available to assist primary care providers. Clinical guidelines, assessment tools, and a whole variety of patient education materials. Each of the websites listed here, of course, link to a variety of other sites. Within the U.S. Department of Health and Human Services, the Office of Minority Health has a variety of very unique resources encouraging couples to not be the norm, because the norm is pregnancies that are not planned. And so there are a variety of tools to encourage couples to be unique, out of the norm, and make sure that they plan their pregnancies to facilitate the health and the well-being not only of them, their children, but their families and communities. Thank you very much for your time and attention. The references you see are available. Further information, as I said, is available at a variety of websites. Again, I hope this information is helpful in your practice in terms of preserving and protecting the health of the next generation.